Thank you, everyone. We will now reconvene the ACIP meeting, and we are moving on to the Chikungunya vaccine session. We have Dr. Beth Bell, the chair of the work group, will provide an introduction and overview of today's session. Dr. Bell.
By way of background, the FDA has now just recently accepted Valneva's BLA application for their chikungunya vaccine and granted priority review with licensure possible as early as August of 2023. No chikungunya vaccine has ever been licensed in the United States or globally, and there are no existing ACIP chikungunya vaccine recommendations. And so to address this, the Chikungunya Vaccines Work Group was formed in May of 2022 to develop policy options for ACIP's consideration for use of chikungunya vaccine among U.S. persons at risk of chikungunya, including travelers, residents of U.S. territories and states with or at risk of transmission, and laboratory workers. Next. So the terms of reference for the Chikungunya Vaccines Work Group are detailed here on this slide. First, to review information on chikungunya disease, including outcomes, to review data on chikungunya epidemiology and burden among U.S. residents, including travelers and persons living in areas at risk for local transmission, to review data on safety, immunogenicity, and effectiveness of chikungunya vaccines, to provide evidence-based recommendation options for ACIP, to identify areas in need of further research for informing potential future vaccine recommendations, and to publish a chikungunya vaccine MMWR recommendations and reports document. Next. Here are the members of the Chikungunya Vaccines Work Group, including myself and my colleague, Dr. Wilbert Chen from the ACIP, CDC lead Susan Hills and Nicole Lindsay. We have a number of extremely helpful ex officio and ACIP liaisons and a very esteemed group of invited consultants that who have already been extremely helpful. Next slide. These are the CDC participants in the Chikungunya Vaccines Work Group. As you can see, people from the Vector-Borne Diseases Division, from the Quarantine and Global Migration Group, Infection Control people, Vaccine Safety, and Global Immunization. Next. So just to go over briefly the previous work group presentation to ACIP on this topic. In October of 2022, we presented an overview of chikungunya virus disease and vaccines and had a discussion about the immunogenicity and safety of Valneva's chikungunya vaccine. Next. And so we're going to build on that with today's session, where we'll have 4 presentations. First is on the global epidemiology of chikungunya with Dr. Susan Hills. Chikungunya in U.S. travelers by Nicole Lindsay. Persistent arthralgia following chikungunya, which is quite relevant to our vaccine considerations, also Nicole Lindsay, and then work group considerations at the end. And next, I think that's the end. So thanks very much, and I'll yield the floor to Susan.
Thank you very much, Dr. Bell, and thank you, Dr. Lee. So to begin today's session, I'd like to present some information on chikungunya virus transmission to provide some background on the overall global patterns and the risk of the disease. As a brief reminder from the work group's presentation at the last meeting, chikungunya is a mosquito-borne disease, with the virus primarily transmitted in an ongoing cycle between humans and mosquitoes. The main mosquitoes involved are Aedes aegypti and Aedes albopictus, which are the same mosquitoes that transmit some other arboviruses, such as dengue and Zika viruses. The disease is clinically characterized by the acute onset of fever and often severe polyarthralgia, And groups at risk for more severe disease include adults older than 65 years of age, people with underlying medical conditions such as hypertension, diabetes, and heart disease, and neonates infected through intrapartum transmission. The details on this map are not important, but it's useful to illustrate the dramatic spread of chikungunya virus that began in 2004 and lasted for about 12 years. After chikungunya virus was first detected in Tanzania in the 1950s, for about 5 decades, it just caused sporadic cases and occasional outbreaks in parts of Africa and Asia. However, in 2004, the epidemiology changed dramatically, beginning with a large outbreak in Kenya and then followed by rapid spread of the virus to Indian Ocean islands and beyond, causing numerous outbreaks as it expanded across the globe. So ultimately, in late 2013, the virus was introduced into the region of the Americas, initially spreading throughout the Caribbean and then broadly throughout South and Central America. Next slide. Because the populations in the Americas were largely immunologically naive to chikungunya virus infection, there was a very large outbreak. More than 2.4 million suspected or confirmed cases were reported during the outbreak period. In the next presentation, you'll see the effects of this outbreak on US travellers as well. Subsequently, the outbreak subsided. During the last 6 years, while there has been some variability in case numbers reported from year to year, typically fewer than about 200,000 cases have been reported annually from the Americas. Next slide. This map shows all countries and territories with past or current transmission of chikungunya virus. Transmission is known to have occurred in the past or be occurring currently in over 110 countries worldwide. I wanted to note that this map is readily available and often referenced, but it's sometimes misinterpreted because it just shows countries and territories that have ever had chikungunya virus transmission, but these locations do not necessarily have any current transmission. Next slide. In fact, understanding the current patterns of chikungunya virus transmission can be challenging. There are some sources of data, such as Ministry of Health websites, WHO websites, and data on traveller cases that are collected by national authorities or published in journal articles. But overall, the available information on chikungunya virus transmission is usually incomplete and typically not available in a timely way. Next slide. When considering the current patterns of chikungunya virus transmission, there are some general overall features of note. The disease occurs in tropical and subtropical regions with very rare outbreaks reported in temperate areas. It's often seen in the same locations where similar Aedes mosquito-borne diseases are found, such as dengue and Zika. Transmission can be impacted by several factors, and these include weather, environmental conditions, pre-existing population immunity, population density, and the type of Aedes vectors present. Next slide. Patterns of chikungunya virus transmission vary in different locations. In Africa, Asia, and Central and South America, the general pattern is ongoing low-level transmission with periodic outbreak activity. This reflects a cycle where immunologically susceptible individuals continue to acquire infection and propagate human to mosquito to human transmission cycles. Outbreaks are unpredictable both in terms of timing and size. Typically, after high incidence outbreaks, low-level transmission continues for many years. Conversely, in island nations, complete cessation of transmission after outbreaks is common. Because they are geographically isolated and often have small populations that develop herd immunity during outbreaks, it's more feasible for interruption of transmission to occur compared with large countries with contiguous borders. Currently, there's no evidence of chikungunya virus transmission in most Pacific Island and Caribbean countries and territories. Nonetheless, in island settings without transmission, there is the ongoing potential for reintroduction of virus, and the risk increases over time as population immunity wanes. Once there is low population immunity, the possibility of re-emergence and an explosive outbreak is high. Next slide. Periodic outbreaks are a key feature of chikungunya virus transmission, and so I'd now like to describe some features of chikungunya outbreaks. In terms of location, outbreaks are more likely in regions with no or mild outbreaks in the recent past, although this is unlikely to accurately predict the location of any future outbreaks, as other factors also contribute. Sometimes outbreaks are very localized and sometimes they are widespread. Once an outbreak begins, it can rapidly increase in size. About 30 to 60% of the susceptible population can be infected within a few months. Huge outbreaks, like those that occurred in the immunologically naive population in the Americas, are unlikely in future. But there is likely to be continued reporting of large outbreaks on an ongoing basis. For example, there is currently an ongoing outbreak in Paraguay with over 50,000 suspect cases reported to PAHO. In regards to the timing of outbreaks, most occur during the rainy season and abate during the dry season, but outbreaks can occur in the dry season. In terms of duration, the period of intense transmission is typically short, often only about 3 to 6 months. Next slide. And finally, the interval between outbreaks is unpredictable and variable, and it can be 20 years or more between outbreaks in any particular location. Various factors likely impact the interval between outbreaks, including the pre-existing population immunity, the buildup of the non-immune population over time, environmental conditions, and other factors. Some countries regularly report outbreaks, but these are typically in different locations of the country. Next slide. So in summary, the key points of the global epidemiology of chikungunya are that the disease mainly occurs in tropical and subtropical areas. Currently, most countries with chikungunya virus activity have low-level ongoing transmission. However, chikungunya is an outbreak-prone disease, and the impact of outbreaks when they occur is important because they can often result in intense transmission, although in general, the duration of any outbreak is short. Thank you very much.
Thank you, Dr. Hills. And it's my understanding we'll move on to Ms. Nicole Lindsay, and then after the next presentation, we'll take clarifying questions on the two presentations together.
Thank you, Dr. Lee. Can you confirm that you can hear me?
We can. Please go ahead.
Thank you. As Dr. Bell mentioned earlier, the work group will be considering recommendation options for chikungunya vaccine use among various groups. The first group that we will be considering is travelers to areas at risk, and therefore I will be summarizing data on chikungunya in U.S. travelers. Next slide. The data I'm presenting are national surveillance data for U.S. travelers and include confirmed and probable cases in residents of U.S. states reported to CDC. All of these cases had laboratory evidence of infection based on either molecular or serologic testing. Cases reported from U.S. territories and associated states were excluded due to difficulties in differentiating travel-associated and locally acquired cases. Prior to 2006, chikungunya was very rarely reported in U.S. travelers. So the data included here are for cases reported for 2006 through 2021. Overall, 4,590 traveler cases were reported during this time frame. Because chikungunya was not a notifiable disease until 2015, we expect that reporting may have been more incomplete during the earlier years. Next. This slide shows chikungunya cases in travelers reported by year for the 16-year period. From 2006 through 2013, cases were rare, with an average of 7 cases reported annually. All of these cases reported travel to areas in Asia, Africa, or the Indian Ocean that were known to have chikungunya activity. There was a large increase in reported cases concurrent with explosive outbreaks in the Americas, with more than 3,700 cases reported in 2014 and 2015 together. Annual numbers of cases have declined steadily since the outbreak in the Americas abated. Next. Overall, 35% of reported cases were male and 65% were female. This predominance of female cases was consistent by year and by age group. A predominance of female cases has been reported in the literature fairly consistently. Some authors have hypothesized that the difference could be due to greater healthcare seeking behaviors among women, as most seroprevalence studies have not shown a significant difference in infection rates by sex. Next. This is the age distribution of travel-associated cases. The majority of cases occurred in persons aged 40 to 59. There were relatively few cases in the very young and older age groups. This age distribution is likely reflective of the age of the traveler population, as infection rates are not expected to differ by age. The age distribution was consistent over time. Next. This graph shows the month of illness onset among travel-associated cases. Although cases occurred in all months of the year, 61% occurred during June through September, which likely reflects popular times of travel, as well as the timing of seasonal outbreaks in locations of travel. Next. Because 2014 accounted for such a high proportion of the total cases, we wanted to see if there was any difference in seasonality for that year, shown here in orange, compared to other years, shown in blue. When the 2014 cases are removed, there is still a peak in the summer months, but the curve is flatter and there is more of a discernible peak in January. Next. This slide shows the clinical outcomes of reported cases. About 18% were hospitalized. In the literature, the reported frequency of hospitalization of chikungunya-infected patients ranges from about 0.5% to 11%, and may be affected by access to medical care, local clinical practices, reporting and testing practices, and frequency of comorbidities and co-infections in the population. The hospitalization rate among cases reported to CDC is high and is likely artificially inflated due to biases of identification and reporting of more severe disease cases in travelers. There were 4 reported deaths. While causes of death were not available, these deaths were among older adults with a mean age of 77 years, and no deaths occurred during the acute illness. The mean time from illness onset to death was about 2 months. Next. This table shows hospitalization rates by age. Hospitalization rates were highest among young children and adults aged 60 and older. Infants were most likely to be hospitalized. 7 of the 17 cases reported in children under 2 were hospitalized. Next slide. This slide shows the region of infection among those where this information was included in the report. More than half of cases, about 54%, were reported to have been infected in locations in the Caribbean. More than 80% were reported to have acquired infection in one of the American regions. Next. Because we know the data in the previous slide were heavily influenced by the 2014-2015 outbreak in the Americas, we looked at region of infection just in the past 5 years. Among the 532 cases reported during that time, 60% were infected in locations in Asia. About 27% were infected in one of the 4 American regions, and about 8% in Africa. Next. This slide shows the 10 most common countries or territories of infection for cases reported since 2006, all of which are in the Americas with the exception of India, which accounted for approximately 9% of cases overall. By far, the highest number of cases, over 1,000, originated from the Dominican Republic. Next. Again, we wanted to look at trends in more recent years without the influence of the American outbreaks. And in the last 5 years, the most common location of infection was India, accounting for about 37% of cases. Most cases originated from Asian countries, although a fair number are still being identified related to travel to American locations. Next. There are several limitations of national surveillance data. Firstly, reported cases are likely an underestimate of the true incidence of disease among US travelers. More severe cases are more likely to be identified and reported, leading to an inflated proportion of severe outcomes such as hospitalization and death. The data provided through national surveillance are often incomplete, particularly for travel history. There's no information available on duration of travel or activities during travel that might be associated with increased risk of infection. Additionally, we do not have information on the duration of specific symptoms or long-term sequelae. Next. In summary, outside of the time of the unprecedented outbreaks in the Americas, relatively few chikungunya disease cases in US travelers are reported annually. Reported cases likely underestimate the true incidence of disease and overestimate the proportions of severe outcomes. Very young children and older adults have the highest hospitalization rates. Cases have occurred among travelers to all regions with chikungunya risk and can occur year-round, with case numbers reflecting levels of chikungunya virus activity in and numbers of travelers to destinations with risk. Thank you. That's my last slide.
Thank you. Both presentations are now open for questions. I don't see any hands raised. I don't think any clarification questions are on the docket. Are there any questions? Dr. Schaffner, go ahead.
Hi, Grace. Thank you for all this. This is very interesting. It was mentioned that there might be some transmission in the United States. Do we have any information on acquisition of a chikungunya infection among residents of the United States who did not leave this country?
I can perhaps answer that question. So there has been very limited evidence of transmission in the United States in just 2 states, Florida and Texas. That was back in 2014, I believe. There were 12 cases of local transmission in Florida, and there has been 1 case of local transmission in Texas.
Thank you.
Puerto
Sorry?
Puerto Rico?
Yes, so there was a large outbreak of chikungunya in Puerto Rico that began in 2014. The last clear evidence of transmission in Puerto Rico was in mid-2017. And I will clarify that one of the questions that the work group is going to consider is use of vaccine in US territories and affiliated states with risk of transmission, and in states in the US with evidence of transmission. But the first questions we are tackling relate to US travelers and laboratory workers. So in future, we do plan to present some additional data in relation to US states and territories.
Thank you.
Thank you. And I think what we'll do is we'll move on to the next presentation because I have a feeling most of the questions will relate to work group considerations. So we'll move on to Ms. Lindsay, if you want to go ahead with the chronic arthralgia after chikungunya.
Thank you, Dr. Lee. So yes, we're going to change track just a little bit and discuss an important sequela of chikungunya infection, chronic arthralgia. Next slide. It's often reported that the acute symptoms of chikungunya typically resolve in 7 to 10 days and that mortality is rare. However, a significant proportion of patients have continued a recurrent arthralgia in the months and years following their acute illness. Other long-term complications have been reported less frequently, including fatigue, depression, alopecia, impaired memory, sleep disorders, and lowered quality of life. Slide. Although other sequelae have been reported, chronic arthralgia is pretty clearly the most significant of these. And so understanding disease burden in relation to this outcome is very important in understanding the potential benefits of vaccination. There are multiple studies that have been published reporting on chronic joint symptoms following chikungunya infection. There's variability in these studies in almost all aspects, including methodology, symptoms assessed, definitions, and ascertainment of symptoms, self-reported versus assessment by a clinician, duration of follow-up, and characteristics of the cohort of patients. There have been a few meta-analyses published, but these also varied in the specific outcomes analyzed and the criteria used to evaluate studies for inclusion. After reviewing the published meta-analyses, we determined that none used the outcome and inclusion criteria that would be most useful in guiding the vaccine recommendation process, and therefore decided to perform our own review and meta-analysis. Next. The primary objective of our review and analysis was to estimate the percentage of patients with chronic arthralgia, defined as greater than or equal to 3 months, following chikungunya infection. We conducted a literature search in Medline for articles describing primary data on arthralgia following chikungunya infection. Articles were excluded if the investigators did not confirm all chikungunya infections by serologic or molecular testing, so studies where only a clinical diagnosis was made were not included, and where the cases were from specific subgroups that might affect disease severity or duration of symptoms. So for example, studies in children or among people with co-infections, or where an abnormally large proportion of cases were hospitalized for acute disease. Non-English language articles were also excluded. These accounted for less than 5% of all articles identified in the original search. Next slide. This slide summarizes our study selection process. The original search identified 1,167 publications, and all titles and abstracts were reviewed. Of those, only 80 required a full text review to determine if they met our criteria. Of those, 27 met the inclusion criteria, and we completed a data extraction using a standardized spreadsheet tool. Next. The 27 included articles accounted for a total of 4,079 chikungunya infected persons. Most of the studies were clustered in one of two time periods, 2005 to 2006 during the outbreaks in the Indian Ocean, and 2014-2015 during the initial outbreaks in the Americas. Overall, 23 studies were conducted among local populations during outbreaks. 4 studies were among travelers to outbreak locations. 14 studies included patients infected in countries in the Americas, 8 in countries in the Indian Ocean, 4 in Asia, and 1 in Europe. Only 4 of the 27 studies included a control group of non-infected persons. There was a range of severity of illness among populations included in the studies and varied demographics of included participants. Next. This slide shows the estimated proportion of cases with arthralgia following illness onset reported by the included studies. There are more than 27 data points included here because some studies reported estimates for multiple time points. Next. We chose 3 time points to generate summary estimates: 3 months, 6 months, and 12 months. Next. There were 7 studies that evaluated arthralgia at 3 months after acute infection, accounting for 733 patients. All studies included patients who sought healthcare for their acute symptoms. There were 2 studies among travelers, 1 among travelers to locations in the Indian Ocean and 1 with travelers to locations in the Americas, and 5 in communities with outbreaks in Brazil, French Guiana, Martinique, St. Martin, and Thailand. In all studies, there was a predominance of females. The studies included patients of varying ages. The study mean or median ages ranged from a low of 35 to a high of 51 years. There was also a range of disease severity from no hospitalizations to 17%. Next. This slide shows the forest plot for the 7 studies. The table includes the location of the study, the number of chikungunya patients included, the proportion with arthralgia at 3 months, and the confidence interval for the proportion. The reported proportion of patients with chronic arthralgia at 3 months ranged from 42% to 86%. And the summary estimate for this time point was 51%, with a 95% confidence interval from 44 to 58%. Next. There were 9 studies that evaluated arthralgia at 6 months, accounting for 961 patients. Again, all studies included patients who sought health care for their acute symptoms. There were 3 studies among travelers, all among Indian Ocean travelers, and 6 in communities with outbreaks in Bangladesh, French Guiana, Martinique, Mexico, Suriname, and Thailand. Again, there was a predominance of females and a range of ages. Here, the study mean ages ranged from a low of 32 to a high of 60, and hospitalization rates ranged from 0 to 33%. Next. Here's the forest plot for the 9 studies. The reported proportion of patients with chronic arthralgia at 6 months ranged quite widely from 13% to 70%. And the summary estimate for this time point was 35%, with a confidence interval from 24 to 47%. Next. There were 10 studies that evaluated arthralgia at 12 months, accounting for 1,539 patients. 9 of these included patients who sought healthcare for acute symptoms. 1 was a population-based sample obtained from persons testing positive during a serosurvey who were asked about symptoms at the time of the blood draw. All studies were conducted in communities with outbreaks occurring in Aruba, Bangladesh, Brazil, Grenada, Italy, Malaysia, Martinique, Reunion Island, and the US Virgin Islands. Again, we saw a predominance of females and a range of ages and hospitalization rates. Next slide. The reported proportion of patients with chronic arthralgia at 12 months also ranged widely, from a low of 19% to a high of 61%. And the summary estimate for this time point was 38%, with a 95% confidence interval from 29 to 46%. Next. So this figure is a little busy, but the main point here is that among the 9 studies that assessed arthralgia at multiple time points, in general, there was a decrease in the proportion over time. Next. As you know, the first task of the work group is to develop recommendations for travelers. So this slide presents results of the 4 studies that were among travelers specifically. These 4 studies had relatively small sample sizes, and due to the methods of patient identification, tended to include more older persons and skew towards those with more severe acute disease. The Simon study included 47 French travelers who acquired illness in locations in the Indian Ocean. A very high percentage, 86%, reported arthralgia at 3 months, and 48% had arthralgia at 6 months. Another study of French travelers identified from a different facility reported almost 60% with arthralgia at 2 years. Notably, different results were reported by a small study of 16 German travelers from the same general outbreak location and time period. Only 13% of cases had arthralgia at 6 months. There was 1 study of Spanish travelers from the outbreak in the Americas, and in that group, 50% reported arthralgia at 3 months. Next. There are quite a few limitations of this work, and I just wanted to highlight a few of the most important ones. First, there's substantial variability among the studies we included in case definitions, populations included, and the findings. Almost all the studies that have been completed are among persons who sought healthcare for their acute disease symptoms and are not representative of all infected persons. There are only a few studies that included a control group to account for any background rates of arthralgia in the population. For the meta-analysis, we used the crude estimates from all studies to calculate the summary estimates. Next. I have 2 slides to summarize the 4 studies that did include a control group of uninfected person. The first 2 were conducted following the Reunion Island outbreak. The first included 199 cases and 199 controls. And at 17 months after onset, the chikungunya cases reported significantly more joint pain than was reported in the control group, 53% compared to 28%. It was estimated that 47% of pain in the cases was attributed to chikungunya infection. The second study was larger, with 512 cases and 582 controls. At 16 months, cases were more likely to report musculoskeletal pain than controls, 43% compared to 17%. Here it was estimated that 60% of pain in the cases was attributed to chikungunya infection. Next. These other two studies were conducted following the outbreak in the US Virgin Islands. The Feldstein study included 165 cases and 167 controls. At 6 months, the difference in arthralgia between case patients and controls was 32% after adjusting for age, sex, and history of arthritis. At 12 months, the adjusted difference was 19%. The Hennessy study included 171 cases and 338 controls. At 12 months, 31% of case patients and 26% of controls reported joint pain. They estimated that only 23% of joint pain in the case patients was attributed to chikungunya infection. Next. To review, this meta-analysis that included patients who almost universally sought healthcare during their acute infection showed that a substantial proportion had chronic arthralgia following infection. There was variability among studies at all time points, but we estimated that about half of patients have arthralgia at 3 months after illness onset. The proportion with arthralgia decreased over time, and just over a third were estimated to have arthralgia after a year. It is very important to understand that these proportions of persons with chronic arthralgia are likely overestimates when the broader population is considered. Firstly, they reflect almost exclusively the healthcare-seeking population who, compared to those who do not seek healthcare, likely have more severe disease. Among the population as a whole, rates would almost certainly be lower. Secondly, the rates do not account for underlying rates of arthralgia in the population. The small number of studies that did include a control group provided variable results, but overall suggested when this background rate of arthralgia was taken into consideration, 20 to 60% of reported arthralgia after chikungunya might be attributable to the prior chikungunya virus infection. Next. In summary, it's difficult to provide a precise estimate of incidence of long-term joint pain after chikungunya. In addition, the percentages of patients with long-term joint pain are likely variable based on several factors, including the severity of acute illness and patient age, sex, and comorbid conditions, particularly pre-existing joint conditions. However, long-term joint pain after infection is an important complication of chikungunya that could be prevented by vaccination. Thank you. I'll pass back to Dr. Lee.
Thank you very much. Are there any clarifying questions on this presentation before we move to the work group considerations? All right, no questions on this end, Ms. Lindsay. So it would be wonderful to move on to the work group plans, timelines, and discussion.
Happy to. So yes, we'll conclude our session by briefly reviewing the work group plans and timelines. Next slide. As Dr. Bell mentioned earlier, FDA recently accepted Valneva's BLA for chikungunya vaccine and granted priority review, so licensure is possible as early as August of this year. The work group is initially focusing on developing recommendations for ACIP's consideration for travelers and laboratory workers, and plans to present the evidence to recommendations frameworks at the October 2023 ACIP meeting. A vote on these recommendations would follow at the February 2024 meeting. We will then be continuing with our discussions to consider recommendations for adults living in US territories and states at risk for outbreaks. Next slide. During the next few months, the work group plans to comprehensively review the vaccine immunogenicity and safety data as a part of the grade assessment. We anticipate making further presentations to ACIP on topics relevant to consideration of vaccine use in territories and US states with risk of transmission in the future. Additionally, we anticipate that over time, there will be additional data on the use of Valneva's vaccine among younger age groups, and there might be additional chikungunya vaccines submitted for licensure in the United States. And we will be presenting those data as they become available. Next. So To conclude, I just wanted to acknowledge all the hard work of the Chikungunya Vaccines Workgroup members, and thank you very much for your attention, and I'll hand back to you, Dr. Lee.
Thank you. This presentation is now open for questions. Dr. Sanchez.
Thank you for that presentation. I was just wondering, is there any consideration for pregnant women since intrapartum and then postnatal through breastfeeding can occur? And actually women, lactating women?
The vaccine is a live attenuated vaccine, so pregnancy will be a contraindication.
Okay, thank you. How about lactating women?
We have not yet started discussions in the work group. Over the next couple of months, we are considering the various factors. So we'll be happy to discuss that in future.
May I ask just a quick question? Well, maybe not that quick, but just in the in the context of climate change, how confident are you about? The epidemiology is likely to be dynamic in the coming years. So I guess, do you feel like we have surveillance systems in place that will allow us to adapt our recommendations to better and really it's understanding where the risk is. So I guess I just have a generic question about sort of what the longer range plans might be around how to think about this, not just for chikungunya, but for other mosquito-borne illnesses.
Yeah, thank you for that question, Dr. Lee, and it's a very good question. As I mentioned, we're really struggling in terms of thinking about the availability of surveillance data. There are some Ministry of Health websites that put out data. They're often not complete or timely. Surveillance is incomplete. There are WHO data, there are our traveller data. So there are a variety of sources, but overall they tend to be incomplete and not timely. And so it is a question that we are we just started in our last meeting and are going to be discussing very much in depth over the next couple of months to try and think about how we're going to make recommendations in the context of sort of limited and not necessarily timely data.
Thank you. We look forward to hearing about it. I don't see any other hands raised. Any questions from the Zoom call? Okay, well, let me thank our presenters from the chikungunya vaccine session, Drs. Bell, Dr. Hill, and Ms. Lindsay. And we will move on now to the dengue vaccine session. Dr. Wilbur Chen is the work group chair, and he will take us through an introduction and overview of today's session.
All right, good afternoon, everyone. Hold on tight. We're going to try to get back on schedule. Let's go to the next slide. So let me remind you for dengue viruses, dengue probably puts half of the global population at risk. That's how extensive dengue virus infections are. There are 4 genetically distinct dengue serotypes, dengue viruses 1 through 4. And infection with one serotype provides lifelong type-specific immunity, but only short-term cross-protection against the other 3 serotypes. And importantly, it is with the second dengue infection that there is this increased risk of severe dengue illness, and this is due to a phenomenon called antibody-dependent enhancement, or ADE. Next slide. So we've already discussed and voted on a vaccine called Dengvaxia, and clinical trials found different outcomes with vaccination with this vaccine among children with and without previous dengue infection. If you click again, we found that children without previous dengue infection had this higher risk of hospitalization in severe dengue if they were vaccinated and then subsequently got a natural dengue infection, which is basically mimicking that second dengue infection that I just warned you about. Click again, and you'll see that children with previous dengue infection were protected from hospitalization in severe dengue when they were vaccinated with Dengvaxia. So next slide. Dengvaxia was recommended in the June 2021 meeting. 3 doses of Dengvaxia are indicated for the prevention of dengue disease caused by these 4 serotypes of dengue in children 9 to 16 years of age, but the provision is that they should have a lab confirmation of prior dengue viral infection, and of course they must be at risk living in endemic areas. Next slide. So our work group, since that June 2021 meeting, we took a hiatus and then reconvened in August 2022 when the work group restarted our meetings to discuss the Takeda product, which we'll be discussing today. It's called TAC 003. And according to this timeline that you can see here, today we'll have a presentation on the efficacy, immunogenicity, and safety from Takeda, and also hear about the work group's interpretation. In June, we plan to have the work group present the grade and cost effectiveness analysis. And then in October, the work group plans to present the ETR and draft recommendations, and we hope to have a vote ready for the ACIP. Next slide. Within the work group, we will continue to review the data through the grade framework. We will evaluate the domains of the ETR as they're related to this vaccine, as well as the cost effectiveness analysis. And we also hope to develop the policy options for the upcoming meeting in October. Next slide. So today, we'll hear about this vaccine, TAC 003, the efficacy, safety, and immunogenicity from Takeda, and we'll also hear the work group's summary and interpretation of these data. Next slide. Last slide. I want to thank my CDC co-leads, Drs. Gabriela Paz-Bailey, Laura Adams, and also Josh Wong. I want to thank my ACIP members that have also been working with me on this work group, Drs. Paling, Bell, and Ms. McNally. And I want to extend my gratitude to the many consultants, liaisons, and contributors to the work group who are all making very valuable contributions to our discussions. Thanks.
Thank you, Dr. Chen. We'll move on to Dr. Biswal from Takeda.
Thank you, Dr. Chen and Dr. Lee. Good afternoon. Thank you for this opportunity to talk about Takeda's dengue vaccine candidate, TAC 003. I'm Sibajas Biswal, clinical lead for this vaccine development at Takeda. These are some of the disclaimers. TAC-03 is an investigational compound that has not been approved by US FDA. Currently, this vaccine is approved for use in UK, Europe, and Indonesia for use regardless of prior dengue exposure status. That is, it can be used in both dengue naive and pre-exposed individuals. Takeda is seeking an indication for this vaccine in the US for prevention of dengue in 4 to 60 years of age, regardless of prior dengue exposure. In my presentation, I'll cover construct of the vaccine, its immune response profile, clinical development, efficacy profile from the pivotal efficacy trial, safety profile from an integrated analysis of placebo-controlled trials, immunogenicity data from the pivotal efficacy trial, and a summary. Let me first describe you the construct of this vaccine. TAC-03 is a live attenuated tetravalent vaccine constructed using the dengue 2 virus as backbone. A dengue-based vaccine was expected to have better chance of protection against the disease. The serotype 2 component, as shown at the top, has a non-chimeric attenuated structure. In constructing the other 3 components, the pre-membrane and envelope protein genes from dengue 2 are replaced with those from other 3 serotypes, dengue 1, 3, and 4. That leads to 4 virus components corresponding each of the 4 dengue serotypes. TAC-03's primary mechanism of action is to replicate locally and induce immune response against all 4 serotypes. This includes humoral-mediated immunity, cell-mediated immunity, and innate immunity. For dengue, there is no immune correlate of protection established. These broad spectra of immune responses likely contribute to protection against infection, virus clearance, and prevention of severe disease. Now I turn to clinical development of this vaccine. The vaccine has been evaluated in 19 completed or ongoing clinical trials in 13 dengue endemic and non-endemic countries. Over 28,000 children and adults in the age of 1.5 to 60 years participated in phase 1 to 3 clinical studies. Clinical development included both baseline seronegative and seropositive participants. Approximately 20,000 participants received at least one dose of TACO3 in clinical development program. Now I move on to the pivotal efficacy trial. This randomized double-blind placebo-controlled trial was designed in accordance with WHO guidelines and was conducted in 8 dengue endemic countries. The trial included more than 20,000 participants of 4 to 16 years of age. This age range was selected to ensure inclusion of both seronegative and seropositive individuals. Also importantly, dengue incidences tend to be higher in this age group in endemic areas. Participants received either TACO3 or placebo by subcutaneous injection into the upper arm. 2/3 received vaccine and 1/3 received placebo in a 2:1 randomization ratio. Baseline samples were collected in all participants to assess baseline serostatus. Active surveillance with weekly contact was in place throughout the study to detect all symptomatic dengue cases. Dengue cases were confirmed through RT-PCR. After 2 doses 3 months apart, the trial had a follow-up period of approximately 4.5 years. Towards the end of this follow-up period, a booster dose was administered to a subset of participants, and that part is currently ongoing. In my presentation, I'll only describe data from the pre-booster part of the trial. Overall, demographics were similar between placebo and vaccine groups. Nearly 28% were dengue seronegative at baseline. The mean age at enrollment was 9.6 years. Slightly more participants were enrolled in Latin America than in Asia. The trial was conducted in a wide geographic area to maximize chances of detecting all 4 dengue serotypes. Shown here is the data from the placebo group illustrating the varying serotype distribution at the trial sites by region. At the Asian site, shown on the right side, all 4 serotypes were reported, dengue 2 being the most common. At the Latin American sites, shown on the left side, the serotypes were mostly dengue 1 and dengue 2, with dengue 1 being the most common. Dengue 4 was generally infrequently reported in the trial, which is also in line with known dengue epidemiology. Let me now show you the key efficacy data, starting with the primary and secondary efficacy endpoints. The trial met its primary endpoint, demonstrating 80% efficacy against symptomatic dengue at the end of first 12 months after vaccination. It also met the key secondary endpoint, demonstrating 90% efficacy against dengue leading to hospitalization at the end of 18 months after vaccination. The trial met all additional secondary efficacy endpoints for which there were sufficient cases to evaluate. This includes efficacy in baseline seropositive and baseline seronegative participants, efficacy by each serotype, dengue hemorrhagic fever, and severe dengue by adjudication committee. 2 endpoints were not met due to low number of cases. Those were efficacy against dengue 4 serotype and efficacy against severe dengue by adjudication committee. Next, let's look at the exploratory analysis performed beginning with long-term vaccine efficacy by baseline dengue serostatus. TACO3 continued to reduce incidence of dengue fever during the 57 months of surveillance. These incidence curves show placebo recipients in solid red and blue lines. Red represents baseline seropositive and blue baseline seronegative. The two dotted lines represents the vaccinees. TACO3 was efficacious soon after first dose with early separation of placebo and vaccine curves, and it remained efficacious through the whole 57 months of follow-up period in both seronegative and seropositive participants. The cumulative efficacy during this time from the first dose was 61% overall, 54% in seronegative participants, and 64% in seropositive participants. Looking at the similar curves for dengue hospitalization, we see TACO3 also reduced hospitalization over 57 months. The cumulative efficacy during this time frame was 84% overall, 79% in seronegative participants, and 86% in seropositive participants. Overall, the vaccine demonstrated protection against symptomatic dengue and those leading to hospitalization, irrespective of prior exposure to dengue over 57 months of follow-up period. Now I turn to further exploratory analysis looking at profile of the vaccine stratified by baseline serostatus at each serotype level. Shown here is the data of all symptomatic cases. In this analysis, efficacy was clear for 6 out of 8 of these subgroups. In seropositive participants, efficacy was seen against all 4 serotypes, as shown in the upper panel. In seronegative participants, as shown in the lower panel, efficacy was shown against dengue 1 and dengue 2, the 2 most common serotypes reported in the trial. The data for dengue 3 in seronegative participants suggested lack of efficacy with a marginally negative point estimate, but with inconclusive results. For dengue 4, there are too few cases in seronegative participants to assess the efficacy profile. Let's now look at the similar data for hospitalized cases. The first thing notable is that the efficacy was consistently higher against hospitalization than it was against any dengue fever. Again, efficacy profile was clear for 4 serotypes in seropositives and for dengue 1 and 2 in seronegatives. If we look specifically at dengue 4 in seronegatives, the bottom row in the lower panel, we see that only a single case of hospitalization, and it was in a placebo recipient. For dengue 3 hospitalizations in seronegatives, case counts were small, result was inconclusive, but the point estimate was negative. Therefore, we look deeper into the data, including a country-by-country analysis. Firstly, it is important to know that while surveillance methodology was same across sites, clinical management of febrile illnesses was according to local standards of care. In other words, thresholds for hospitalizations were not defined in the trial protocol, and trial centers were able to hospitalize according to local standards. As a result, there was considerable variance in hospitalization rates as shown in this graph, looking specifically at the placebo group. Sri Lanka was an outlier as cases were proactively hospitalized based on local dengue testing, regardless of clinical condition. In all other countries, hospitalization was due to clinical need. As a result, 68% of cases in Sri Lanka were hospitalized compared to an average of 16% across all other countries. Let's look at a sensitivity analysis excluding the data from Sri Lanka. In seropositive participants, we see high efficacy against hospitalized dengue across all 4 serotypes that is not impacted by hospitalization practices in Sri Lanka. In seronegative participants, we see that dengue 1, 2, 4, and 4 results are also not impacted by hospitalization practices in Sri Lanka. Only dengue 3 was the exception and therefore requires cautious interpretation. We saw earlier there were numerically more hospitalized cases in the vaccine group compared to placebo, although case counts were small. Excluding the Sri Lanka data, we see that the case counts are proportionate and there is no difference between the two groups. These data must be considered in the context of a number of factors. First, although case surveillance and detections were the same across all sites, hospitalization approach was unique in Sri Lanka. Second, more than 85% of all dengue 3 cases in seronegative participants occurred outside Sri Lanka, but there is no evidence of an increased hospitalization as we see in this slide. Third, dengue 3 cases in seronegative participants in Sri Lanka were reported from one site during year 3. None were of higher DHF grade or were adjudicated as severe dengue. Finally, when case counts are small, the 1:2 placebo to vaccine randomization can increase chance observations unfavorable to the vaccine. In summary, there is little evidence that vaccination increases the risk of hospitalization in seronegative recipients infected by dengue 3. This will be further monitored and studied in the post-marketing setting. Let me now review the safety data from an integrated analysis of placebo-controlled trials. Solicited reactions shown on the left side occurred more frequently in the vaccine group than the placebo group. Unsolicited adverse events shown on the right side had similar incidence in both vaccine and placebo groups. Most frequent vaccine-related unsolicited adverse events were injection site pruritus, bruising, and pyrexia. Shown here is an integrated analysis of serious adverse events in the placebo-controlled trials. Rate of serious adverse events were 8% in the vaccine group and 9.6% in the placebo group. By preferred terms, those were generally similar across the two groups, except for dengue-related events which were lower in the vaccine group. None of the deaths reported were related to the investigational products. There are also no deaths caused by dengue in the development program. Turning now to immunogenicity. The primary immunological endpoint of all studies in the program was based on neutralizing antibodies. I'll present the data from pivotal efficacy trial in participants seronegative at baseline. Seropositivity rates in seronegative participants were used to measure the proportion of responders to the vaccine, with tetravalent seropositivity providing a measure of response to all 4 dengue serotypes. This is based on achieving the lowest detectable level of antibody response. To clarify, it is not synonymous with correlate of protection. As shown here, seropositivity rates after 1 dose of TACO3 were greater than 90% for each serotype, with 85% of vaccinees having a tetravalent response as shown on the right side. After the second dose, nearly 100% of the participants had a tetravalent response among those who are seronegatives. Shown here are the geometric mean titers of antibody response over time. The solid lines represents the titers in vaccinees against each serotype. The dotted lines are the placebo data. Titers increased after first dose for all serotypes, with highest levels against dengue 2, shown in the red solid line. Titers against dengue 1, 3, and 4 were similar. Persistence of antibody titers were seen to 51 months after first vaccination in these seronegative participants. To summarize, TACO3 has been evaluated in 19 clinical trials in 13 countries. Data from the pivotal trial showed long-term efficacy in both baseline seronegative and seropositive participants. TACO3 is immunogenic against all 4 serotypes. Data from the pivotal trial suggested varying efficacy profile by serotype. It was efficacious against all 4 serotypes in seropositive participants. In seronegative participants, it was efficacious against dengue 1 and dengue 2, the serotypes most commonly seen in the trial. In baseline seronegative participants, the data suggested lack of efficacy against dengue 3 and did not allow assessment of dengue 4 due to low incidence. However, the long-term follow-up did not conclude a high risk of hospitalized or severe forms of dengue associated with TACO3. Totality of data did not indicate harm. Safety data from integrated analysis of placebo-controlled trials showed TACO3 had an acceptable safety profile. To conclude, TACO3 represents a new tool that can have a critical role in reducing dengue burden globally and in the United States. Thank you for your kind attention, and I'll be happy to take any questions.
Thank you very much. This presentation is now open for questions. Dr. Long.
Thank you. It's late in the afternoon, so maybe I missed it. Did I not see that there was adequate serologic response to type 3 in naive individuals, but lack of efficacy against 3? And to what do you ascribe this?
Thank you for that question. So we did see immunological response against dengue 3, those who are seronegative. And indeed, we did not see efficacy. So currently, we do not fully understand why the vaccine did not show efficacy against dengue 3. We have looked into a number of factors, such as immunological basis and also genotype. And we don't have a definitive answer currently.
Dr. Talbot.
And I just want to clarify, it looked like it was specific to only dengue 3 when you removed the important data that was from Sri Lanka. When you don't remove the Sri Lankan data, I mean, are there other discrepancies?
My apology, I did not quite get the question. If you might like to clarify.
It looked like there was a discrepancy between immunologic response and clinical efficacy for dengue 3 and only dengue 3, but that looked like that was the data from the study where the Sri Lankan data was removed, which was quite surprising. If you go back to the complete data, were there other discrepancies between immune response and clinical efficacy?
So here is the data for efficacy for hospitalized cases by baseline serostatus. And so here is the data where we saw a negative point estimate for dengue 3 hospitalizations. And when we removed Sri Lankan data, we no more saw this negative point estimate.
Is the slide that's showing, though, does that contain the data from Sri Lanka?
Yes.
Thank you.
Thank you. I don't see any additional hands raised. Oh, one more. Dr. Daly, sorry.
Yeah, I think, given what we've learned about dengue disease and dengue vaccination, I think sort of continuing evidence of absence of harm is going to be important. And I understand that there were differences in hospitalization rates in Sri Lanka, but that doesn't necessarily mean to me that it's invalid data. So could you, I don't know how to say this other than to say, provide more of an understanding of whether or not we should include the data from Sri Lanka, because otherwise I would conclude that it should be included as intended in our interpretation of whether there's absence of harm or no absence of harm. Thank you.
That is indeed very important. So when we looked at the sensitivity analysis, so we saw that when we include Sri Lanka, so we have a negative point estimate, and when we exclude Sri Lanka, we don't have a negative point estimate. So the intention here is not to really remove the data and look at the data, is to understand whether this represents an increase in severity of cases. And when we looked at the Sri Lankan cases, we had a situation that we had 6 cases at one site, and all those 6 cases were in the vaccine group and none in the placebo group. And this can happen in the context of a 1:2 randomizations where twice many subjects are there in the vaccine group. And because in Sri Lanka, typically cases are hospitalized, so those cases which were locally detected dengue, they were hospitalized for monitoring purposes. Now we specifically looked at those 6 cases, and those were not DHF grade 3 or 4. They were not adjudicated as severe by the blinded case adjudication committee. So in our view, those cases do not represent an increase in severity of cases in vaccinees. And this is most likely a chance observations in the context of varying hospitalization practices, and also the fact that we did not see efficacy for these serotypes. And in summary, our conclusion is that we have to look at this data cautiously, but they do not suggest risk. They rather represents the lack of efficacy that we have seen at all symptomatic case level.
Dr. Sanchez?
Thank you for that presentation. I just want to be clear. In the seronegative children, individuals who received the vaccine, with subsequent infection, there was no enhancement of disease. Just to be clear, like it was seen with Denvaxia.
So that's a very important point here. We have looked into this data very carefully. This is the data for hospitalizations, the dengue which led to hospitalizations. And the upper 2 graphs here, the upper 2 curves here, they are the placebo curves, and the below 2 curves are the vaccine curves. So blue here is seronegative at baseline. And if we specifically focus at the blue lines, those are those who are seronegative at baseline. And we see a very clear difference between the placebo and vaccine curves, and which represents 79% efficacy over 57 months. And this indicates that seronegative population benefits and there is no disease enhancement.
Dr. Paling.
Thank you so much for this presentation, and I'm so glad that you put up the slide, because when we talked earlier about when you get dengue, you have about 2 years of protection across serotypes, and then that abates, and that you worry about an increased severity of disease. And you can see at 24 months, that's where we're starting to see in the seronegative, seropositive difference. Thank you.
Thank you for that observation. So in fact, in seronegatives, we also see a higher incidence, the blue line on the top, which represents the placebo curves. And so we also see that the widening of the curves continues through the 57 months. In fact, in the last 18 months, efficacy of the vaccine was 100% against hospitalized cases. So in the long term, where dengue protection against dengue is very important from an evaluation point of view, given the precedent, So we think there is no decline in efficacy specifically for hospitalized cases, and we believe that represents that there is no disease severity increase, and there is continued protection over the long term.
Thank you. We'll move on now, and thank you for the presentation. We'll move on now to work group considerations with Dr. Gabriela Paz-Bailey.
Thank you, Dr. Lee. I'm going to be presenting on the workgroup summary and interpretation of TAC 003 efficacy, safety, and immunogenicity data. Takeda's trial was a double-blinded placebo-controlled study. As you heard, participants were enrolled and randomized to vaccine or placebo in a 2-to-1 ratio, and it included children ages 4 to 16, was conducted across 5 countries in Latin America and 3 countries in Asia. It had a follow-up time of 57 months after the first dose. The safety set included about 20,000 participants, of whom 28% were seronegative at baseline. The primary endpoint was virologically confirmed dengue, or VCD, due to any serotype measured at 1 year after the second dose in the series. And the secondary endpoints were stratified by the participant serostatus and by dengue serotype, and included the outcome of VCD, hospitalizations for dengue hemorrhagic fever, as well as the trial-specific severe dengue definition. I will be summarizing today the data for a follow-up time of 57 months and will include data from all the trial sites. I will show the vaccine efficacy for the outcome of VCD first for all serotypes and serostatus combined, and then stratified by serostatus, and then stratified by serotype. Significant efficacy estimates are bolded, and non-significant efficacy estimates where confidence intervals cross 0 are in gray boxes. So we start with an overall vaccine efficacy for all serotypes and all serostatuses combined for VCD of 61%. As a reminder, seropositive participants are those who have had dengue at least once before vaccination, and seronegative participants are dengue naive. So stratified by serostatus, we see 64% VE in seropositives on the left and 54% in seronegatives on the right. When stratified by individual serotype, we appreciate that it has efficacy against all serotypes in seropositives, but negative vaccine efficacies with 95% confidence intervals crossing 0 for dengue 3 and dengue 4. The workgroup interpretation for the outcome of VCD is that there is evidence of protection against all 4 serotypes for seropositives. And for seronegatives, there is significant protection against dengue 1 and dengue 2, but no efficacy for dengue 3 and dengue 4, and insufficient data to rule out an increased risk of VCD for these 2 serotypes. We see a similar trend for the outcome of hospitalizations. There is a vaccine efficacy of 84% against hospitalization for serostatuses and serotypes combined. Stratified by serostatus, there is significant protection in both seropositives and seronegatives. Stratified by serotype, there is significant protection for seropositives against serotypes 1 through 3, and a calculated vaccine efficacy of 100% against dengue 4. But there were only 3 events for the serotypes, and they were all in the placebo arm. For seronegatives, there is significant protection for dengue 1 and for dengue 2, and a negative vaccine efficacy for dengue 3 of 88%, with confidence intervals crossing 0. There was only 1 hospitalization event for dengue 4 in the placebo arm. So while the negative vaccine efficacy for dengue 3 among seronegatives suggests a higher rate of hospitalization in the vaccinated participants compared to placebos, I do want to emphasize that the hospitalization rate for the serotype was overall low for both the vaccine and the placebo arms in the trial. This table shows the hospitalization case counts by serotype. For dengue 3, there were 3 hospitalizations in the placebo arm and 11 in the vaccine arm, which had twice as many participants as the placebo arm. And that equals a hospitalization rate of 0.04 per 100 person years for the placebo and 0.07 per 100 person years for vaccinated participants. And for dengue 4, there was only 1 case in the placebo arm. So the workgroup interpretation of this data are that in seropositives, there is protection against all serotypes, although very few hospitalizations for dengue 4. For seronegatives, there is protection for dengue 1 and 2, and once again, few hospitalizations for dengue 4. There is no efficacy for dengue 3 against hospitalization and insufficient data to rule out the possibility of an increased risk of hospitalization among vaccinated children. We will now look at the outcome of severe dengue by 2 different outcomes, dengue hemorrhagic fever by the 1997 WHO definition, and then also the trial-specific definition for severe dengue. I will show vaccine efficacy by serostatus, but will not show it by serotype since there were very few events. There is a vaccine efficacy of 70% against dengue hemorrhagic fever for serostatuses and serotypes combined. When stratified by serostatus, there is a VE of 81% in seropositives and negative 3.4 in seronegatives. There are only 5 DHF cases in the vaccine arm and 13 cases in the placebo arm for seropositives. And in seronegatives in the placebo arm, which had half as many participants as the vaccine arm, there were only 2 DHF cases, 1 due to dengue 1 and 1 due to dengue 3. There were 4 DHF cases in the vaccine arm, and they were all due to dengue 3. And moving now to the second definition, the trial definition of severe dengue, we see a vaccine efficacy of 70% for serostatuses combined, and it has a confidence interval that goes from negative 25 to positive 93. When stratified by serostatus, the VE is 90% in seropositives. For seronegatives, there were only 2 cases, both of which occurred in the vaccine arm and were due to dengue 3. So the workgroup interpretation of this data is that overall it is difficult to draw conclusions, particularly stratifying by serotype due to the small number of events. For seropositives, we see protection against DHF and trial-defined severe dengue. For seronegatives, there was no efficacy for either outcome. I will talk now about immunogenicity and safety. The immunogenicity data for the vaccine was evaluated in a subset of participants. Among seronegative vaccine recipients, geometric mean titers calculated using PRNT50 were highest for dengue 2. GMTs were stable over 51 months after the first dose for dengue 1, 3, and 4, and decrease over time for dengue 2. However, dengue 2 titers remained higher than the other serotypes at 51 months. Solicited adverse events were higher among recipients of the vaccine compared to placebo, and unsolicited adverse events were similar between the vaccine and placebo. Serious adverse event rates were similar among the vaccine and placebo arms. Only 1 of the serious adverse events was deemed to be related to the vaccine, and 4 were related to the placebo. The most common serious adverse events were dengue fever and dengue hemorrhagic fever, which were both higher in the placebo compared to the vaccine. There were 16 deaths in the vaccine arm and 10 in the placebo arm, and none of the deaths were related to the vaccine. So in summary, we have 5 conclusions that we believe are clear in the data presented. TAC-003 protects seropositive recipients against VCD and hospitalizations due to any serotype. Additionally, TAC-003 protects seronegative recipients against VCD and hospitalizations for dengue 1 and dengue 2. However, the vaccine does not protect seronegative recipients against VCD and hospitalizations for dengue 3. Dengue 4 efficacy assessment is limited by the low number of events. The data suggests no protection against VCD for dengue 4, and there was only one dengue 4 hospitalization. And finally, unsolicited adverse events, serious adverse events, and deaths were similar in the vaccine and placebo arm. We have identified 3 observations that we're still working through in the work group. First, the work group is discussing the implications for the unknown vaccine efficacy against dengue 4 hospitalization among seronegatives. Second, as I said, there is no efficacy against VCD or hospitalization for dengue 3 among seronegative recipients compared to of the vaccine compared to placebo, and the data are insufficient to rule out an increased risk among those vaccinated. And finally, we're still debating the significance of the immunogenicity data because there is no clearly defined correlate of immune protection for the dengue vaccine. And I want to thank the ACIP dengue vaccine work group, and I can take any questions.
Thank you so much, Dr. Paz-Bailey. Dr. Lair.
Thank you so much. Your summary slides were excellent and took a lot of confusing information and made them very clear, and I really appreciate you doing that. Thank you.
Thank you. Lots of nods around the room, Dr. Paz-Bailey. We really appreciate your interpretation and sharing that with us. Well, we're going to go ahead and move on. Thank you very much to our dengue vaccine group. That was an excellent set of presentations. And we would like to go on to Dr. Mona Marin, who will present on 25 years of varicella vaccination program in the U.S. Dr. Marin?
Hi, good afternoon. I'm here and I just requested control the slides.
You should hopefully have it soon.
Thank you.
And just a warning, they might kick us out at 5:40, so.
No.
But we're very much looking forward to this presentation, so.
Thank you, and our program really appreciates the opportunity to provide the committee on this very busy day of discussions. A summary of 25 years of impact of the varicella vaccination program in the United States. Historically, varicella was considered a disease of little consequence, a rite of passage during childhood, too mild to warrant prevention. That misconception started to change after the first cases of fatal varicella were reported in mid-1950s in children treated with newly introduced immunosuppressive therapy that cured several serious diseases but unmasked the lethal potential of the varicella zoster virus, or VZV. Then, in late 1960s through early 70s, immunosuppressive treatment was increasingly used as systemic steroid therapy for organ transplantation or childhood cancers. Leukemia, previously almost always fatal, was cured in about 80% of children, only to have many of them die of varicella before immune reconstitution. Varicella thus no longer seemed too inconsequential to justify the development of a vaccine. In 1974, research from Japan announced a varicella vaccine that contained an attenuated strain of VZV after studies showed impressive results on small numbers of healthy children and adults and children with leukemia in remission. In the United States, there was initially controversy about the use of a varicella vaccine, with important concerns being the risk for latency and persistence of immunity. However, fear of varicella in the leukemic and other immunocompromised children led to trials in the US in the early 1980s in children with leukemia that demonstrated vaccine efficacy and safety and pioneered subsequent studies in healthy people where the vaccine was also safe and effective. In 1995, the varicella vaccine was licensed and recommended in the United States, and the United States became the first country with a routine varicella vaccination program. ACIP made a scientifically informed yet bold decision in recommending varicella vaccination. There was debate around the time of vaccine recommendations on whether the health burden of varicella justifies a vaccination program, whether the vaccine would be accepted by parents and providers, whether the varicella program would shift the burden of varicella from children who have milder disease to adults who have more severe presentations, and there is also a risk during pregnancy, and whether the program would increase herpes zoster incidence. Next, I will present the US varicella program to address pre-vaccine burden, recommendations, coverage, and effectiveness. Before vaccine, varicella did represent a significant health burden, both medical and societal, in the United States, which assumed more importance once other preventable causes of health burden and mortality, such as polio and measles, had been controlled. In the United States, approximately 4 million cases of varicella occurred every year pre-vaccine, approximating the birth cohort, resulting in 11,000 to 13,000 hospitalizations and 100 to 150 deaths. The greatest health burden occurred in children, with more than 90% of cases, 70% of hospitalizations, and about half the deaths from varicella. As I mentioned, the US varicella program started in 1995 when one dose was recommended for routine vaccination of 12 to 18 months of age, with catch-up vaccination for older children and other susceptible persons. In 2007, the policy was changed to a routine 2-dose childhood program, with the first dose at 12 to 15 months of age and the second at 4 to 6 years, catch-up vaccination of persons who had received 1 dose, and vaccination of all eligible susceptible persons. The main rationale for the policy change was continuing low-level community transmission with outbreaks in highly 1-dose vaccinated elementary school populations, although smaller and less frequent than pre-vaccine. Regarding acceptability, the varicella program implementation was highly successful. The graph on the left shows 1-dose coverage for children 19 to 35 months of age for varicella vaccine in blue and, as comparison, MMR in gray. High coverage was attained among young children with 89% by the end of the 1-dose program in 2006 and remained around 90-91% since then, with coverage levels similar to those of MMR, a more mature program. The graph on the right shows the rapid uptake of the second dose after the 2-dose recommendation in 2007, coverage reaching a median of 93% by 2020 in 6 states, with good immunization electronic records, again approaching the coverage of 2-dose MMR. The second vaccine characteristic that influences vaccine impact is the performance of the vaccine. 1 dose of varicella vaccine is moderately effective in preventing varicella of any severity in the low 80%, and highly effective in preventing moderate or severe varicella at more than 97%, while the second dose adds 10% or more improved protection against varicella of any severity. Next, I will describe the impact of the program on varicella. Starting with the incidence. In 4 states that consistently reported varicella cases to the national surveillance system since before vaccine introduction, Incidence declined by more than 97% from the pre-vaccine period through 2018-2019. The decline was impressive during the one-dose program with more than 86%. The inset in the upper right shows varicella incidence during the two-dose program, and the graph is on a log scale. During this period, incidence declined further 90% from the end of the one-dose program. This graph presents the decline of varicella incidence by age group during the two-dose program, the gray bars, compared with the end of the one-dose program, black bars. Incidence declined in all age groups, indicating additional control added by the second dose and no increase in disease in older ages. The greatest decline was in 5 to 9 and 10 to 14-year-olds, primary recipients of the second dose. Additionally, in 7 states with consistent outbreak reporting, the number of outbreaks declined by 82%. Moving to varicella hospitalizations now. Overall, compared with the pre-vaccine period, varicella hospitalization rates declined 90% by 2019. In the graph, the overall hospitalization rate is showing by the continuous black line with marks. Although difficult to see in the graph, the hospitalization rates continue to decline during the two-dose program. While rates inform on the frequency of an event and allow comparisons among populations, absolute numbers are also instructive to define the burden in a population. In this table, the second column presents the average annual hospitalizations in the pre-vaccine period. The third column presents the average annual hospitalizations in 2018, 2019, and the last column, the percent declines in hospitalization rates. We see dramatic declines in rates of over 94% in all age groups younger than 50, with the greatest declines in children and adolescents. Annually, more than 10,500 varicella hospitalizations are now prevented, including more than 1,250 among infants and more than 4,200 among 1 to 4-year-olds. We also saw large declines for deaths. The overall varicella mortality rate has declined 89% from the pre-vaccine period to 2017-2019, and most of this decline occurred during the one-dose program. Similarly to hospitalizations, the mortality rates declined in all age groups. In persons younger than 50, which this graph presents, we have gone from an annual average of 84 deaths pre-vaccine, with varicella as the underlying cause, to 3 deaths in 2018-2019, with deaths practically eliminated among those younger than 20, a 99.4% reduction in rates. In 5 out of the last 9 years, no deaths, underlying or contributing, were reported in this age group. And lastly, a summary of herpes zoster trends during the US varicella vaccination program. As I mentioned earlier, before the routine varicella vaccination program was adopted, there was concern by some experts that decreased circulation of VZV and therefore less external boosting would lead to an increase in herpes zoster in adults. This graph presents herpes zoster trends in persons aged 30 years or older, born before the start of the varicella vaccination program. In this age group, herpes zoster incidence increased during the earlier study years, continuing a period of decades of increases, but with no acceleration following introduction of the varicella vaccine, and with deceleration in later years, starting in 2007 with the oldest age groups. Among children and young adults, age-specific herpes zoster incidence declined in a stepwise pattern once each age group was comprised mostly by persons born during the varicella program, and therefore likely vaccinated, showing by the dashed lines. You can see that the incidence among 1 to 14-year-olds is converging at the lowest levels. To conclude, the US varicella vaccination program has been successfully implemented, resulting in substantial disease prevention and societal savings over the last 25 years. The varicella vaccine has shown good effectiveness that has been maintained to date and has a favorable safety profile. High vaccine coverage was reached and maintained. The program prevented morbidity and mortality with large declines. Approximately 91 million varicella cases, 238,000 hospitalizations, and 1,900 to 2,400 deaths have been prevented over the 25 years of the program. The program is highly cost savings with $23.4 billion net societal savings to date. And the US data do not support prior predictions that the varicella vaccination program would increase herpes zoster incidence among adults and documented reduced herpes zoster incidence among children and adolescents born in the vaccine era, with reduction due to the varicella program likely to extend to the entire population over time. Details of the 25 years of the US experience with the varicella vaccination program, saving lives and preventing illness, were included in a JID supplement released later last year. I would like to thank the co-authors of this presentation, the JID supplement contributors, and to acknowledge the efforts of thousands of nurses, physicians, pharmacists, and our public health colleagues who implemented and monitored this immunization program over the years. Thank you.
Thank you so much for that presentation. Thank you so much for the tremendous work you've done over the last few decades. Dr. Paling would like to ask a question or make a statement.
No, I just wanted to say thank you. I think it's really important to highlight what you don't see, and that what you don't see can be forgotten, and it's really important to take this time. And I just want to say thank you for demonstrating the profound impact.
Thank you. And Dr. Sanchez?
No, absolutely. I want to applaud all of those who came before us and made those recommendations. But I also want to add how much easier it made my life as a neonatal infectious disease person. I don't remember giving VZIG now for many, many years, where it was a common place where, VZIG administration and then in the NICU as well. So it's really impacted other aspects of neonatal care. Thank you.
Thank you. And I'm so glad you went back to slide 20, because my hope is we can take this slide and replicate it for all of the vaccines we discussed today, so that 25 years from now we'll have a reunion and be able to say we did as much, made as much progress as you have done with your team. So thank you so much, Dr. Merritt. Oh, there's more people who want to say hello and congratulations. Dr. Schaffner. Dr. Schaffner, you disappeared. So we'll go to Dr. Kimberlin.
Dr. Marin, thank you very much. This is David Kimberlin, editor of the AAP Red Book. I think as well, in addition just to the phenomenal presentation you just gave and the testament that it really made to the overall program, mention of Dr. Takahashi and his decades of work with this virus as he attenuated it and ultimately got it to a point where the U.S. could take it forward into the first program in the world, is really worth just taking a moment to reflect those, as Dr. Sanchez says, who've come before.
Absolutely. And thank you for your kind words. It's really a team effort. It's a 25-year program. It's CDC people, but it's people in the field who really implemented the program and also collected the data to allow us to monitor. So, yeah, thank you. they belong to them primarily.
Dr. O'Leary.
Yeah, I just want to echo the same sentiments. We joke in the world of prevention that when we do our jobs really, really well, nothing happens. But this is clearly a lot that's happening, and we don't usually get thank yous for this type of work. But I just want to say thank you for all of your work and the work of the team at CDC and the others that were so instrumental in the development and implementation of this program. Thanks.
And Dr. Schaffner, you get the last word.
Well, I would like to add my congratulations and thanks to Dr. Marin for a wonderful presentation. I would like to give a little recognition, and perhaps even more than that, to all the people in all the states who got varicella vaccine included in school immunization laws. Those laws were very important in establishing those high immunization rates and maintaining them over the years. True not only for varicella, but many other vaccines also.
Thank you so much. Dr. Marin, thank you so much for presenting. And I want to thank my ACIP members for a very set of robust discussions today, and we will now adjourn. See you tomorrow morning.